Hi. It is actually 12:34 a.m. and I want to sleep really bad. But I'm gonna be going through the basically lecture stuff for the anatomy test. So basically, I'm gonna be going through everything for exam 2, which includes integumentary, skeletal, joints, and muscles. So yeah. Um I guess we'll start with the thick, which is thick skin. So thin skin has only stratum corneum, granulosum, spinosum, and basal. So there's epidermis and dermis. So thick skin has there's the stratum lucidum included. So it'll be the stratum corneum, stratum lucidum, stratum granulosum, spinosum, then basal. Dermis is composed of collagen, elastic fibers, reticular fibers, and fibroblasts, lots of blood vessels, sweat glands, sebaceous, and nerve endings. The papillary layer has is a thin zone, and the particular area is a layer is deeper and thicker layer of the dermis. They have smooth muscle piloerector muscles that raise your hair basically, and then dermal papillae, which are upward finger-like extensions of the dermis. And it kind of helps create fingerprints. The hypodermis is subcutaneous tissue. There's more areolar and adipose, and then basically binds skin, and drugs introduced by injection are usually put in here. So skin color is determined by 3 skin pigments: melanin, keratin, and hemoglobin. So melanin is like black. Has eumelanin, which is brownish black, pheomelanin, which is reddish yellow. Keratin is from carrots and yellow veggies. Hemoglobin is pink. Well, like it causes pink. So yeah. Okay, so we got lots of skin markings. There's friction ridges or fingerprints. There's flexion lines, which is like digits, palms, wrists, elbows. So it kind of marks where the skin folds during flexion. Freckles and moles, which are aggregations of melanocytes. And there's hemangiomas, which are also called birthmarks. And these are caused by benign tumors of dermal blood capillaries. Okay, so we got accessory skin organs, which are hair follicles, sebaceous glands, and sweat glands, and also nails. So hair, it's also called pilus, and it's found everywhere except for palms and soles, ventral and lateral surfaces of fingers and toes, distal segment of the finger, lips, nipples, parts of the genitals. There's 3 kinds of hair. There's lanugo, which is fine, downy, unpigmented. It is on fetuses. And then vellus, which is fine, pale hair that replaces the lanugo by time of birth. Women have more of this type of hair than men. And these are all like children hairs. And then terminal hairs are longer, coarser, and usually more heavily pigmented. This forms the axillary and pubic hair and male facial hair, eyebrows, scalp, and eyelashes. Hair is divided into 3 zones. There's the bulb, which is where the hair originates, the root, which is the remainder of the hair in the follicle above the bulb, and then the shaft, which is the portion above the skin surface. So there's a structure of the follicle. So the medulla is the core of the cells, and the cortex is the bulk of the hair. The cuticle is this thin, scaly cells that overlap each other. So that's kind of like on the outside. So medulla is close, the core, cortex is kind of outer, cuticle is the most outer. So the hair cycle in growing contains anagen, which is the growth stage, catagen, which is the degenerative stage, and then telogen, which is the resting stage. Some conditions, alopecia is thinning, hirsutism is undesirable hairiness, and then male pattern baldness. It's just specific regions where it's lost. Okay, talk about nails. Fingernails and toenails are stratum corneum cells packed with hard keratin. So the nail plate is the hard part of the nail. The free edge overhangs the fingertip. The nail body is visible, attached part of the nail, and then the nail root is proximally under the overlying skin. Okay, so we're talking about some exocrine glands of the skin. The skin has 5 types of glands. There's merocrine, apocrine, sebaceous, and ceruminous, and then mammary. So the sweat glands are the merocrine and apocrine glands. And merocrine are also known as eccrine glands. These are perspiration, and they're simple tubular glands. Apocrine glands occur in the groin, anal region, armpits, areola, bearded area, and mature males. And the ducts lead to hair follicles. And the sweat is milky, thicker, and has fatty acids and develop at puberty and are responsible for pheromones. All right, the third type of gland is sebaceous glands, produces sebum and opens the hair follicle and keeps basically it has a Hawkins secretion of oil and keeps skin and hair from becoming dry. And if they're blocked, they become acne. Ceruminous glands are only found in the external ear canal, and it's sebum mixed with dead epithelial cells to form earwax, also known as cerumen. So mammary glands are in breasts, and it's for milk, and they're basically modified apocrine sweat glands. You can treat acne with benzoyl peroxide, salicylic acid, antibiotics, vitamin A, and retinoids. So basically, regeneration of the integumentary system is repaired in one of two ways: regeneration, which is the replacement of damaged or dead cells, or fibrosis, which is like basically scarring and functional activities are not restored. Talking about some burns. First degree burns only involve epidermis. Second degree involve epidermis and part of dermis. Third degree involve all 3 layers of the skin, require hospitalization, and may need debridement or skin grafts. The burn severity can be measured by the rule of nines, estimates the surface area of burns. The rule of nines is total body area. So the head and neck is 9%, upper limbs 18, trunk 36, perineum 1%, and lower limbs 36%. So the reduced number of stem cells in skin is connected with aging, fewer collagen fibers, crease lines form, immune response decrease, hair follicles bruise thinner hair or none. There's UV radiation, accelerates aging, and can cause skin cancer. Botox is Clostridium botulinum toxin, blocks nerve impulses, and decreases wrinkles. Basically, developmental aspects of the integumentary system as the kid is infant to the adulthood. It's the skin is thickens and accumulates more subcutaneous fat. Sweat and sebaceous gland activity increases, leading to acne. Aging skin becomes thin, dry, itchy. Elasticity decreases, increased risk of cancer, hair thinning. There's 3. The most common cause of skin cancer is UV radiation. There's 3 types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. Melanoma is the most dangerous. It's highly metastatic and resistant to chemotherapy, and originate from pre-existing moles that get larger. So you can detect this early by the ABCD rule: asymmetry, border irregularity, color, and diameter. So basically, if it's 6 millimeters in diameter. Also, if it's elevated. Squamous cell carcinoma is second most common skin cancers. It's curable if it doesn't spread. I'm assuming basal is not really important. Okay, so we're gonna move on to skeletal. So skeletal, let's see. Okay. There's 4 classes of bones. There's long bones, short bones, flat bones, and irregular bones. So irregular bones, example of vertebrae. Flat bones, example cranial bones. They're flat dense surfaces, basically. Short bones are carpals and tarsals. Long bones are humerus. So there's regions of a. Oh, there's 2 types of bones. They're compact, which is 80% of bone mass, and then spongy, which is 20%. There's regions of a long bone. Okay, so there's the diaphysis, which is the long cylindrical shaft, basically. Contains red bone marrow in children and yellow bone marrow in adults. And there's the medullary, which is also called the marrow cavity. There's the epiphysis, which is the knobby region at each end of the long bone. The proximal epiphysis is the closest to the body trunk. Distal is the farthest. And there's articular cartilage, which covers the joint surface and reduces friction. There's the metaphysis, which is the region where the bone widens and transfers weight between the diaphysis and the epiphysis. Epiphysis. The epiphyseal plate is located within the metaphysis. It's the growth plate. Yeah. So basically, how it goes is the proximal epiphysis is up here. The metaphysis is kind of like the neck, I guess. The diaphysis is the long part. Another metaphysis part, and then the distal epiphysis, which has the articular cartilage on both ends of the epiphyses. I think that's it. The epiphyseal line is kind of like on the articular epiphysis. Hardening process of bone is called calcification or mineralization. Pretty much. They have osteons. The periosteum has the inner and outer layer. That's the very outer part of the bone. It's basically periosteum, and then compact bone with osteons, and then cancellous bone with trabeculae, and then the medullary cavity on the inside. So yeah. The nutrient foramina is on the bone surface. There's central canals. There's circumferential lamellae. Interstitial lamellae. Interstitial is between the osteons, and then the circumferential lamellae is part of the circle. The canaliculi are, I believe, the little lines of the osteons. Okay. The diplo is the spongy layer in the cranium that absorbs shock. Okay, now we're gonna move on to spongy bone. So they're consisting of spicules and trabeculae filled with red bone marrow, few osteons, no central canals. There's the bone marrow, red bone marrow, and yellow bone marrow. Okay, so there's 4 types of bone cells. There's osteogenic, osteoblast, osteocytes, and osteoclast. So osteogenic cells are the stem cells, and they change into osteoblasts, which are bone-forming cells. And then they turn into osteocytes, which are basically like they're in lacunae, canaliculi, and then dissolving cells are osteoclasts. They're found on the bone surface, and they basically increase surface area. Um, so the matrix is composed of 1/3 organic and 2/3 organic matter. So the organic matter is synthesized by osteoblasts, like collagen, carbohydrate, protein complexes, and then the inorganic matter is 85% hydroxyapatite, 10% calcium carbonate, and then other materials. Okay, now we're gonna move on to joints. Okay, so joint is where any two bones meet, bone and cartilage or bones and teeth meet. And the joint name is basically derived from the names of the bones involved. So there's 4 anatomical category: bony joints, fibrous joints, cartilaginous joints, synovial joints, and then 4 functional categories, which is synostosis, synarthrosis, amphiarthrosis, and diarthrosis. Okay, so for bony joints, these are synostosis, and these are immovable joints. The gap between the two bones ossifies. So, for example, the frontal and the mandibular bones, and the cranial sutures in elderly, and the basically the physes fuse in adults, basically. And this can occur in either fibrous or cartilaginous joints too. Fibrous joints, these are adjacent bones attached by collagen. These types of fibrous joints are based on length of fiber. So there's sutures, gomphoses, and syndesmoses. So an example of sutures is like the your skull, like it's like fused together or whatever. And then gomphoses is just like not super like not super thick close together. It's just like kind of like loose fibers. And then syndesmoses is inside, like kind of like inside your ulna and radius, and it's very like thick. Not thick, but like, you know. Sutures are slightly movable fibrous joints. There's serrate, interlocking wavy lines. There's lap, which is overlapping beveled edges. And then plane, which is straight, non-overlapping edges. So serrate is like ziggity zaggity. Lap is just like that. And then plane is like that. Gomphoses is a fibrous joint attached to from a tooth to the socket. So it's held in place by periodontal ligament, collagen fibers, and it allows the tooth to move, but not too much, you know. Syndesmoses is a fibrous joint where two bones are bound by longer collagenous fibers. There's more mobility, and there's an interosseous membrane. It's most mobile in the radius and ulna, and less movable in tibula to fibula. Okay, third type of joint. Cartilaginous joints are two bones linked by cartilage. There's 2 types of cartilage bones. There's synchrondosis and symphysis. Synchrondosis are bones that are bound by hyaline cartilage, so the epiphyseal plate in children and the first rib attachment to sternum. The other ribs are synovial joints. But anyways, the symphyses, cartilaginous joints, are 2 bones joined by fibrocartilage. There's no space between these bones. So, for example, pubic symphysis and bodies of vertebrae and intervertebral disc, there's little movement, but there's a collective effect. So, like the intervertebral disc is symphyses, cartilaginous joints. Okay, fourth type of joint, synovial joints. These are separated by fluid-filled joint space. These are most important, likely to become diseased, and the most movement. For example, fingers. Okay, we're going to talk about the synovial joint anatomy. So there's articular cartilage on the surfaces of the connection bone parts. The joint cavity separates both of the articular surfaces. The synovial fluid is kind of like it like separates the articular, No. It's like the lubricant in the joint cavity. And the joint articular capsule is kind of like on the outside, like of all the bones and stuff. So there's accessory synovial joint structures, tendons, which are they attach muscle to bones, stabilize joints, ligaments, which are tough connective tissue that attaches one bone to another, bursa, which is fibrous sac filled with synovial fluid, um, where tendon passes over bone or between bone and skin, tendon sheaths, which are elongated cylindrical bursae wrapped around a tendon. So these are around like basically your shoulder and stuff. Okay. In a few synovial joints, fibrocartilage goes inward from the joint capsule. The meniscus in the knee is where two cartilages extend inward from the left and right, but not entirely cross the joint. Exercise warms synovial fluid. The cartilage swells, and it helps protect cartilage from wear and tear. Repetitive compression of cartilage during exercise squeezes fluid and metabolic waste out of the cartilage. When weight removed, cartilage absorbs synovial fluid like a sponge, taking oxygen and nutrients to the chondrocytes. Without exercise, cartilage deteriorates more rapidly from inadequate nutrition and waste removal. So, okay, we're talking about joints and lever systems. So, long bones act as levers to enhance the speed or power of limb movements. So, there's a lever, which is any elongated, rigid object that rotates around a fixed point called a fulcrum. And the rotation occurs when the effort overcomes the resistance at some other point. So, the fulcrum is like the thing in the middle, and then there's like a little board, right? The resistance is the thing that's heavy, and the effort is the thing trying to move the resistance. So the first class lever has the fulcrum in the middle between the effort and the resistance. So the atlanto-occipital joint lies between the muscles on the back of the neck and the weight of the face. So the loss of muscle tone occurs when you nod off in class. So I guess the effort is like right here. That's equal like amount of thing. A second class lever is where the fulcrum is very like it's like over here. And the resistance from so like the effort is all the way over here, the resistance here, the fulcrum's here. So it's harder for the effort to lift up the resistance. So this is from the muscle tone of the temporalis muscle between the jaw joint and the pull of the digastric muscle on the chin as it opens the mouth quickly. So resistance up here, fulcrum is right here. Effort is like trying to open my mouth. It's like a lot harder, basically. And then the third class lever is where the fulcrum is right here. Right here. Effort, and then the resistance over here. So I guess it's kind of easier, I guess. I don't know. Harder, I guess. Oh no, the second class lever is easier because the resistance is between the effort and the fulcrum. But here the effort's in between the resistance and the fulcrum, so this is the effort applied by the biceps muscle applied to the forearm. So this is the effort, this is the fulcrum, and whatever I'm holding in my hand is the resistance. So yeah, that's definitely harder. The range of motion is where the joint can move, and it's determined by the structure of the surface, ligaments and joint capsules, and muscle tone. So there's multi-axial joints like the shoulder and hip, and then other joints are monoaxial, biaxial. There's multiple types of synovial joints. There's ball and socket joints. This basically just looks like a head that fits within a cup-like socket. Example is the shoulder and hip joints. These are the only multi-axial joints in the body. There are condylar or ellipsoid joints. These are oval convex surface of one bone fits into a concave depression on the other. So kind of like the radiocarpal joint of the wrist, the metacarpophalangeal joints at the bases of the fingers. These are biaxial joints, so there's movement in two planes. So I can do this and I can do this. I guess I can kind of go around, right? I guess I can do that and then that, but it's kind of hard, I guess. Yeah. Um. Anyways, there's saddle joints where both bones have articular surface that is concave in one direction and convex in the other. So the trapezial metacarpal joint at the base of the thumb, the sternoclavicular joint where the clavicle articulates with sternum. So this is a biaxial joint, more movable than a condyloid or hinge joint, and this gives you the opposable thumb, basically. There's plane or gliding joints. These are flat articular surfaces where bones slide over each other with relatively limited movement. So this is monoaxial. So this is the carpal bones of the wrist and the tarsal bones of the ankle and articular processes of vertebrae. There are hinge joints where one bone with a convex surface fits into a concave depression of another bone. So this is elbow joint, like ulna and humerus, the knee joint, like the femur and tibia, and the interphalangeal joints. This is also monoaxial and only move in one plane. There are pivot joints where one bone has a projection that is held in place by a ring-like ligament. So the bone spins on its longitudinal axis. So the atlantoaxial joint, where the axis and the atlas are. So it's a transverse ligament. And then also the proximal radial ulnar joint allows the radius to rotate during pronation and supination. And these are also monoaxial. Okay. So movement of synovial joints, the zero position is the position of the joint where the person is in a standard anatomical position, right? So the joint movements are described as deviating from the zero position or returning to it. So flexion is movement that decreases joint angle. So it's common in hinge joints. Extension is movement that increases the joint angle. So flexion is like bringing my hand up to my shoulder, and the extension is moving it back down. Hyperextension is moving it beyond the zero position. So let's say zero position is me putting my arm out, my palms like my hands all the way down. Extension is when my hands like out, and hyperextension is when my hands all the way up. So yeah. Abduction is if I were to put both my hands on top of my head. Adduction is putting it back to my side. Hyperabduction would be raising arm over back or front of the head. Hyperadduction would be crossing fingers or crossing ankles. Toes too. Elevation and depression. Elevation is just going up. Depression is going down. Protraction and retraction. Protraction is anterior movement. Retraction is posterior movement. Circumduction is one end of the appendage remains stationary where the other end makes a circular motion. For example, me putting my arms in arm circles. Rotation, where the bone spins on its longitudinal axis. So it's like if I were to give somebody a hug, but to not move the top of my arm. So I just like be hugging, like using my elbows and stuff. So medial rotation turns the bone inward and lateral turns it outward. Supination and pronation. So supination turns palm to face anteriorly and pronation turns palm to face posteriorly. So there's special movements of the head and trunk. There's flexion, forward bending, extension, straighten trunk or neck, hyperextension, bending backward, lateral flexion, tilting the head or trunk to the right or left at the midline. There's special movements of the foot, dorsiflexion, elevation of toes, which is like putting your foot all the way up, like to step on your heels. Plantar flexion, which is like ballerina type. There's inversion, which is moving your feet inwards, like your toes inwards and your heels. Keep your heels same. And then eversion, which is moving it outwards. So there's this orders of the joints. There's dislocation, bursitis, gout, tendon ligament sprain or tear, and arthritis. Arthritis is a broad term of pain and inflammation. Most common joint disease treated by rheumatologists. Osteoarthritis, most common form. Rheumatoid arthritis is autoimmune attack against the joint tissues. Can result in ankylosis, which is the solidly fused immobilized joint. Treatments can be NSAIDs, joint supplements, arthroscopy, arthroplasty, or with a positive or negative prosthetic. That's it for skeletal. Now we're going to move on to the last thing, which is muscles. I can't breathe. Okay, half of the body weight is a muscle. There's 3 kinds: skeletal, cardiac, smooth. Specialized for one major purpose, which is to convert chemical energy into mechanical energy. There's characteristics. There's excitability, conductivity, contractility, extensibility, and elasticity. So excitable means it's responsive, stuff like that. Each skeletal muscle is an organ. Muscle fibers are bundled within a fascicle. Fascicle has many muscle fibers. There's 3 concentric layers of wrapping connective tissue components. There's the epimysium, the perimysium, and the endomysium. So the epimysium wraps the whole muscle, the perimysium wraps the fascicle, and the endomysium wraps individual fibers. The epimysium is wrapping everything, including the perimysium, which is wrapping the endomysium, basically. The connective tissue has a tendon, which is a cord-like structure of a dense, regular connective tissue, and aponeurosis, neurosis, which is a thin, flat sheet of dense, irregular tissue. There's deep fascia, which separates individual muscles, and superficial fascia, which are areolar and adipose connective tissue that separates muscles from skin. I don't know how to describe this. Okay, there's muscle attachment. There's indirect and direct. So indirect attachment to bone. So the tendons bridge the gap. The collagen of the endomysium, perimysium, and epimysium is continuous, and it has again aponeurosis and a retinaculum, which is a connective tissue band that separates tendons from muscles. And then there's direct fleshy attachment to bone, which is literal separation between muscle and bone, and muscle seems to emerge directly from bone, actually. And the margins of brachialis and lateral heads of triceps brachii, that's where you can see that. Some muscles insert on the fascia of the tendon or tendon of another muscle or collagen fibers of the dermis. So there's muscle origins and insertions. The origin is the bony attachment at the stationary end of the muscle, and then the belly, which is the thicker middle region, and then the insertion, which is the bony attachment into the mobile end. So the origin is where it like stays still, and the insertion is where it moves, basically, like the joint is. Okay, there's functional groups. There's prime movers, brachialis, for example, synergist, biceps brachii, antagonist, and fixator. Okay, prime mover, brachialis, synergist, biceps brachii, antagonist, triceps brachii, and fixator is a muscle that holds scapula firmly in place, like rhomboids. So skeletal muscles are vascularized, has extensive blood vessels. Skeletal muscle is also innervated by somatic neurons. So there's nerves and blood vessels. Parts of a muscle cell, there's a sarcoplasm, which is the cytoplasm, multiple nuclei, and sarcolemma, which is the plasma membrane that has transverse tubules and voltage sensitive calcium channels. So basically, the sarcolemma is the plasma membrane that surrounds all of the fibers, and then there's bundles of myofilaments with multiple, nuclei. The triad includes the terminal cisterna, the T-tubule, and then the terminal cisterna. Well, it's a T-tubule separating two cisterna, I guess. There's also myofibrils inside of a muscle cell. There are bundles of myofilaments. And then there's sarcoplastic reticulum, which is the internal membrane, similar to the smooth ER. The terminal cisternae, which is blind sacs of sarcoplasmic reticulum, contains calcium pumps that import calcium, and calcium release channels, basically. The myofilaments are contractile proteins within myofibrils. There are two types. There's thick filaments and thin filaments. Thick filaments consist of bundles of many myosin protein molecules, and thin filaments consist of twisted strands of F-actin and G-actin monomers. Basically, thick looks like just straight lines, and then thin looks like it's twisted with like G-actin tiny beads with F-actin like strands, I guess. Like it looks like a little twisty licorice. And so basically, a thick filament is just a whole bunch of like it looks like a whole bunch of ropes pulled tight, and then like water droplets, but they're actually myosin molecule heads. Myofilaments are elastic filaments. They have titin and connectin. They attach thick filament to Z disc and prevent overstretching. And yeah. Let's see, there's striations. The A band is thick filaments and thin filaments. The I band is thin filaments and connectin, basically. Myofilaments are arranged in repeating units called sarcomeres. They're delineated at both ends by Z discs. The position of thick and thin filaments give rise to alternating I and A bands, or striations, of course. I bands are light-appearing regions that contain only thin filaments and bisected by Z discs and get smaller when muscle contracts. An A band is a dark-appearing region that contains thick filaments and overlapping thin filaments, contains H zone and M line, and make up the central region of sarcomere. The H zone is the central portion of the A band, and there are only thick filaments present. No thin filament overlap disappears with maximal muscle contraction. The M line is the middle of the H zone and is a protein meshwork structure and its attachment site of thick filaments. So basically, the sarcomere has A band, which is dark, has thick and thin filaments overlap. The H band, which is the middle of the A band, has only thick filaments. The M line, which is the middle of the H band. The I band, which is the lighter band, which has thin filaments only. And the Z disc, which is thin filaments and elastic filaments in the middle. Structural and functional proteins in sarcomeres like connectin extends from the Z disc to the M line, and dystrophin, which anchors some microfibrils. Duchenne muscular dystrophy, DMD, is the most common type of hereditary skeletal muscle disease dystrophies. So this is defective or insufficient dystrophin. Sarcolemma damage. Problems begin in early childhood, not curable, and probably don't live beyond age 30. The microscopic anatomy of skeletal muscle. Okay. Muscle fibers have abundant mitochondria. Myoglobin within cells allows storage of oxygen. Glycogen is stored for when fuel is needed quickly. Creatinine phosphate can quickly give up its phosphate group to help replenish ATP supply. Okay, I'm talking about the innervation of skeletal muscle fibers. A motor unit is a motor neuron and all the muscle fiber it controls. So it has the axons of motor neurons from spinal cord or the brain, and The number of fibers innervates varies. So small motor units have less than 5 muscle fibers. Large motor units have thousands of muscle fibers. So the small motor units allow for precise control, and large motor units allow for production of large amount of force, but not precise control. Fibers of a motor unit are dispersed throughout the muscle. The synaptic knob is the expanded tip of the motor neuron axon, houses synaptic vesicles, small sacs filled with neurotransmitter acetylcholine, has calcium pumps in plasma membrane, and has voltage-gated calcium channels in membrane. There's a motor end plate, which is a specialized region of sarcolemma with numerous folds, has many ACH receptors. Plasma membrane protein channels open by binding of ACH allow sodium entry and potassium exit. There's also a synaptic cleft, which is a narrow fluid-filled space, separates the synaptic knob from the motor end plate. The acetylcholine esterase resides here. Okay, and so the neuromuscular junction is the location where the motor neuron innervates muscle and is usually the mid-region of muscle fiber. Has the following parts: synaptic knob, synaptic cleft, and the motor end plate. So the synaptic knob is on top, and the synaptic cleft separates the synaptic knob and the motor end plate. Motor end plates are just is on the bottom, basically. I don't know where I'm at. Oh, I'm at the end. Muscle fibers exhibit resting membrane potential. Okay. Well, I think I'm done. So I'm gonna end that stream right now. And work on chem or sleep, and then work on chem in the morning. Bye.